We'll be breaking down all major concepts covered on the exam. But imagine this. A patient walks into the clinic complaining of severe constipation.
Right, which happens all the time.
Yeah, exactly. And a total loss of their sense of smell. Plus, their partner says they've started violently acting out their dreams in the middle of the night.
Which is a terrifying combination, honestly.
Totally. So you might think you're looking at a GI issue, an ENT problem, and like a sleep disorder.
Yeah.
But what if you are actually looking at the very first footprints of a devastating movement disorder?
Right.
You know, years before a single muscle ever starts to tremble? Welcome in. If you are a Canadian medical student currently staring down the barrel of the MCCQE, you are in the exact right place. I'm Harvey.
And I'm Donna.
And we are dedicated MCCQE reviewers. Our entire goal here is to help you master this massive mountain of exam material without feeling completely overwhelmed.
But before we get into the clinical material today, I just need to give a quick, very necessary disclaimer. This deep dive is strictly for medical education and exam review. It is not medical advice, and all clinical decisions in the real world should always involve a qualified healthcare provider.
Absolutely. And today we are pulling our insights directly from reliable StatPearls articles covering neurology section S08. We're diving headfirst into a topic that is, quite frankly, guaranteed to show up on your exam, which is movement disorders.
Yeah, it's a huge topic. Our mission today is to conquer the high-yield exam presentations, the diagnostic traps, and, the core management strategies for three major heavyweights.
Yeah.
So we're doing Parkinson's disease, spasticity, and dystonia.
The big three.
Exactly. And we are going to focus heavily on the underlying mechanisms here, because just memorizing a list of symptoms, well, it won't save you on the MCCQE. You really have to understand the why behind the clinical presentation to navigate the traps they set for you.
Okay, let's unpack this. We have to start with the most heavily tested movement disorder of them all, right? Parkinson's disease.
Oh, absolutely.
The classic motor triad is drilled into every medical student. You've got resting tremor, rigidity, and bradykinesia. But the MCCQE often goes after, the nuances of those three.
They do. The specifics definitely matter. Take the resting tremor, for example. The board examiners want you to know that it is typically asymmetric at onset.
Right, it starts on one side.
Yeah, and it's that classic pill-rolling tremor that happens when the limb is fully supported against gravity.
Yeah.
Then you have the rigidity. This isn't just a generic tightness in the muscles.
It's very specific.
Exactly. When you range their joint, you'll feel a constant uniform resistance throughout the entire movement. It feels exactly like bending a lead pipe.
Hence, lead pipe rigidity.
Right. And if a tremor is superimposed on that rigidity, it creates this ratcheting sensation, which is where the term cogwheel rigidity comes from.
Got it. And then bradykinesia, which is that generalized slowness of movement. You see it in their fascinating gait.
Those short shuffling steps.
Yeah, where it looks like they are constantly trying to catch their center of gravity. And there is even a fascinating historical trivia note in the source material about micrographia.
Yeah.
Right?
Oh, the shrinking handwriting.
Yeah. Historians actually retrospectively diagnosed Hitler with Parkinson's just by tracking the shrinking size of his handwriting in documents over the years.
That is wild.
Right. But, okay, going back to that resting tremor, there's a specific clinical scenario that feels like a major trap for students trying to differentiate it from an essential tremor.
Oh, it is a massive trap. Often, a vignette will describe a patient who has a tremor at rest. Then when they go to pick up a coffee cup or a book, the tremor vanishes.
Which is typical for Parkinson's.
Right. But then they hold that book in front of them in a steady, maintained posture. A few minutes go by, and suddenly the tremor comes back while they are still holding it.
And this is where students get tripped up.
Totally. Students will read tremor during maintained posture and immediately jump to essential tremor. But that is actually the classic re-emerging tremor of Parkinson's disease.
Okay, wait. So it vanishes with the initial action, but returns when the posture is maintained and, their attention drifts.
You nailed it.
So the key differentiator there is that time delay. An essential tremor would just be present the entire time they're reaching for and holding the book, right?
Right.
Whereas this Parkinsonian tremor takes a break and then re-emerges.
Exactly. And to add another layer to the diagnosis, you have to remember that a tremor isn't even strictly required to diagnose Parkinson's.
Wait, really?
Yeah. If a patient has clear, undeniable bradykinesia combined with lead pipe rigidity, you could make the diagnosis. The absence of a tremor does not equal the absence of Parkinson's.
That's a huge point. Okay, let's look under the hood at the pathophysiology, because this ties directly back to that scenario I brought up at the very beginning of the deep dive.
The gut symptoms.
Yes, the textbook definition is the loss of dopaminergic neurons in the substantia nigra pars compacta, characterized by the accumulation of alpha-synuclein protein into Lewy bodies.
That's the classic textbook line, yeah.
But the way this pathology spreads through the nervous system is just wild. It follows something called break staging, which looks a lot like a retrograde invasion.
It really does. What's fascinating here is the sheer anatomical journey of that alpha-synuclein pathology. According to break staging, the misfolded proteins do not spontaneously generate in the midbrain.
They start somewhere else entirely.
Right. The pathology actually begins way outside the central motor centers. It starts in two places, the anterior olfactory nucleus and all the way down in the gut, specifically within the enteric nervous system's myenteric plexus.
Wow.
And from the gut, it literally travels retrograde up the vagus nerve. It hits the medulla first, climbs up through the pons, and finally, eventually, reaches the substantia nigra.
Which perfectly explains that bizarre clinical timeline. This is why a patient will present in your clinic complaining of chronic constipation, because the enteric nervous system is compromised.
Exactly.
And they present with anosmia, the loss of smell, because the olfactory nucleus is hit. And they develop REM sleep behavior disorder, where they lose that normal muscle atonia of REM sleep and physically act out their dreams.
Because the brainstem sleep centers in the pons are degenerating.
Right. And all of this is happening years before the pathology reaches the midbrain to cause a motor tremor.
Yeah, you're seeing the silent footprints of the disease. By the time the resting tremor starts, the patient has already lost a massive percentage of their dopaminergic neurons.
They're already way behind the 8-ball.
Exactly. Now, when it comes to management, levodopa combined with carbidopa remains the gold standard. Levodopa crosses the blood-brain barrier and converts to dopamine.
And carbidopa.
Carbidopa does not cross the barrier. Its entire job is to block the peripheral enzyme due to decarboxylase.
Okay, so it protects the levodopa in the bloodstream.
Right. This prevents levodopa from converting to dopamine in the periphery, which is crucial because peripheral dopamine causes severe nausea by stimulating the area postrema.
Oh, and it can cause cardiac arrhythmias too, right?
Exactly. You really don't want dopamine just floating around in the bloodstream.
But levodopa has a ticking clock on it, doesn't it? Over time, the therapeutic window narrows drastically and patients start experiencing severe fluctuations.
The on-off phenomenon.
Yeah, and levodopa-induced dyskinesias. That's why the guidelines often lean towards starting younger patients on dopamine agonists like pramipexole or ropinirole just to delay those motor complications.
That's the current strategy for younger patients, yeah. But you have to be extremely careful with your differential diagnosis on the exam. If you see a patient with Parkinsonian motor signs, you need to actively look for red flags that point away from idiopathic Parkinson disease.
Like what? What's the first thing we look for?
The first thing you do is a thorough medication review. Traditional antipsychotics, like haloperidol, actively block dopamine D2 receptors in the striatum.
Ah, so they mimic the disease.
Perfectly. They cause extrapyramidal symptoms that look indistinguishable from Parkinson's motor signs. The clue in the vignette will be a lack of that non-motor prodrome. They won't have the years of constipation and anosmia.
The vignette will just say they started an antipsychotic 3 months ago and now they are stiff and slow.
Exactly.
What about the neurodegenerative mimickers, the Parkinson-plus syndrome?
Oh, the exam loves these because they test your neuroanatomy. If the patient has Parkinsonism, but also profound early autonomic failure, like severe orthostatic hypotension where they pass out when standing up, or urinary incontinence, you need to think multiple system atrophy or MSA.
Okay, MSA for autonomic failure.
Right. In MSA, the alpha-synuclein accumulates in oligodendrocytes rather than neurons, severely damaging autonomic pathways.
And the other big one is progressive supranuclear palsy, or PSP.
Yes. With PSP, the hallmark is prominent, early postural instability leading to backward falls, and a vertical gaze palsy.
Meaning they can't look up or down?
Yeah. Usually down. The patient physically cannot look down. The pathology involves tau protein accumulation, causing severe atrophy of the midbrain tegmentum and the superior colliculus, which controls vertical eye movements.
And on an MRI, this midbrain atrophy looks like a hummingbird, right?
Yes. That is a classic radiology pearl. the hummingbird sign.
Love a good radiology animal sign. Okay, so we've seen what happens when the basal ganglia loses dopamine, resulting in this constant lead pipe rigidity. But what happens when the brakes of the central nervous system are cut entirely?
Meaning the upper motor neurons.
Exactly. When the descending pathways that keep our muscles in check are damaged, the resistance wouldn't be constant anymore, right?
No, it wouldn't. And this brings us to spasticity. If you passively range a limb and the resistance changes depending on how fast you move it, you are dealing with spasticity.
So speed matters here.
Yes. By definition, it is a velocity-dependent increase in muscle tone. It is the hallmark clinical sign of an upper motor neuron, or UMN lesion.
So how does a UMN lesion actually cause this?
Think of it like a car seatbelt. If you lean forward and pull the seatbelt slowly, it glides out perfectly smoothly. There's no resistance.
Right.
But if you hit the brakes and the belt is yanked fast, the mechanism locks up completely, stopping you in your tracks.
Okay, I like that analogy.
In the human body, your upper motor neurons constantly send inhibitory signals down the spinal cord to dampen your muscle stretch reflexes. If a stroke, multiple sclerosis, or a spinal cord injury damages those upper motor neurons, that descending inhibition is gone.
So the brakes are cut.
Completely. The reflex arc in the spinal cord becomes hyperexcitable. So when you stretch the muscle quickly, the stretch receptors panic, fire back to the spinal cord, and cause a massive involuntary contraction.
And on physical exam, certain muscle groups overpower others due to their natural strength. That's why you see the classic thumb and palm deformity in spastic patients, where the fingers wrap tightly around an adducted thumb and the wrist is flexed.
Right, that classic posturing.
You'll also see clonus, which is that rhythmic, alternating contraction and relaxation when you abruptly dorsiflex the ankle.
Yes, and clinicians grade this velocity-dependent resistance using the modified Ashworth scale from 0 for normal tone up to 4, where the limb is completely rigid in flexion or extension.
Okay, so how do we manage this? Because managing this hyperexcital state follows a heavily tested stepwise approach.
It does, and step 1 isn't even a medication. It's the removal of noxious stimuli.
Wait, really?
Yeah, if you have a patient with chronic multiple sclerosis who suddenly presents with a drastic, painful worsening of their spasticity, your first move is not to double their muscle relaxers. You have to search for a hidden trigger.
Because their spinal cord is completely uninhibited, any pain signal coming in from the periphery, like a urinary tract infection, a deep vein thrombosis, a pressure ulcer, or even just like an ingrown toenail, hits that hypersensitive reflex arc and sends it into overdrive,
Causing their muscle tone to skyrocket. That is the exact mechanism.
Okay, so check for a UTI first.
Always. Once you've ruled out or treated the noxious stimuli, then you move to step 2, which involves oral medications.
And the board examiners want to know that you understand how these drugs work and why they are dangerous, right?
Oh, they love testing the dangers. Let's look at baclofen. It's a GABA-B receptor agonist. It works centrally in the spinal cord to presynaptically reduce calcium influx, which dampens the release of excitatory neurotransmitters like glutamate.
But the black box warning on baclofen is intense. You can never abruptly stop it.
Never.
If a patient runs out of their prescription, they go into severe withdrawal. The sudden lack of GABAergic inhibition leads to a massive storm of excitatory glutamate.
It's a nightmare for the nervous system.
They develop seizures, hallucinations, extreme hyperthermia, and a rebound in spasticity so severe it can cause rhabdomyolysis and acute renal failure.
You must taper baclofen slowly. That is highly testable. Next up is tizanidine. This is an alpha-2 adrenergic agonist, working centrally to increase presynaptic inhibition of motor neurons.
And there are a couple of board traps here, too.
Yes, 2 major ones. First, it undergoes extensive hepatic metabolism, so you have to monitor liver function tests. Second, it is strictly contraindicated with strong CYP450 inhibitors, specifically the antibiotic ciprofloxacin.
Ah, so if a patient on tizanidine gets a UTI and you prescribe Cipro,
It blocks the metabolism of tizanidine. The drug levels spike, leading to profound hypotension, bradycardia, and dangerous sedation.
that is a classic question stem right there. And then we have dantrolene, which takes a completely different route.
It does. If we connect this to the bigger picture, dantrolene is highly unique among antispasmodics. While baclofen and tizanidine act centrally in the spinal cord, dantrolene acts peripherally, directly at the muscle fiber itself.
Right at the source.
Exactly. It binds to the ryanodine receptor on the sarcoplasmic reticulum, blocking the release of calcium into the cytoplasm. Without calcium, the actin and myosin filaments cannot cross-bridge efficiently, which physically weakens the muscle contraction.
And this peripheral mechanism is exactly why dantrolene is also the antidote for malignant hyperthermia, right?
Spot on. But the exam warning here, similar to tizanidine, is hepatotoxicity. It carries a high risk of fatal liver damage, particularly in females over the age of 30 on chronic therapy.
Good to know. Are there any other oral options?
The last oral option is diazepam, which is a GABA facilitator that hyperpolarizes neurons. But its clinical utility is pretty limited because it is profoundly sedating and impairs memory. It makes it a really poor choice for patients who have suffered traumatic brain injuries.
Makes sense. So when oral medications fail or the systemic side effects are just intolerable, we move to step 3, which is local and surgical interventions.
Yes. And the heavy hitter here is botulinum toxin.
Botox.
Exactly. You inject it directly into the spastic muscle belly. The toxin gets taken up into the presynaptic nerve terminal, where it cleaves a specific protein called SNAP25.
And without SNAP25, the snare complex can't form. If the snare complex can't form, the vesicles containing acetylcholine cannot fuse with the membrane.
Right, meaning acetylcholine is never released into the neuromuscular junction. You've basically created a localized chemical denervation.
So cool. And clinically, you follow the rule of 3s for Botox, right?
Yeah, it's a great mnemonic. It takes about 3 days to start working, 3 weeks to hit its peak effect, and the duration lasts about 3 months before the nerve sprouts new endings and the injection needs to be repeated.
I love the rule of 3s. And what about for patients with severe, widespread spasticity?
For them, we can surgically implant an intrathecal baclofen pump. By delivering the drug directly into the cerebrospinal fluid, you completely bypass the blood-brain barrier.
So you can use a way lower dose.
Exactly. A much lower dose with significantly fewer systemic side effects, like the sedation we talked about earlier.
Okay, so we've covered the constant rigidity of Parkinson's and the velocity-dependent stiffness of spasticity. But there is a third category of movement disorder.
Dystonia.
Yes. What if the patient is dealing with involuntary, maintained twisting contractions? Contractions that force the body into abnormal postures, but wildly fluctuate depending on what the patient is actively doing.
Right. Dystonia is a highly dynamic disorder. It is completely different from the passive tone abnormalities we just discussed. It might only trigger when a patient attempts a highly specific, overlearned motor task.
Like what?
Writing, for instance, triggers writer's cramp. Playing a musical instrument can trigger musician's dystonia. Or it might present focally, like cervical dystonia, also called torticollis, where the sternocleidomastoid and other neck muscles contract involuntarily, painfully pulling the head twisted to one side.
Okay, here's where it gets really interesting. You walk into the exam room and a patient has severe torticollis. Their neck is locked and spasming. But then they lift one finger, lightly touch their own chin, or gently rest the side of their face against the wall, and the spasm completely vanishes.
It's like magic.
They can look straight ahead normally, but the second they remove their finger, the neck violently twists again. This is called a jest antagonist, or a sensory trick. How on earth does a light touch on the skin override a debilitating muscle spasm?
It's fascinating, right? That sensory trick is the skeleton key to understanding the pathophysiology of dystonia. Historically, medicine viewed dystonia as a structural lesion in the basal ganglia, much like a stroke.
But that's not true.
No. We now understand it is a neurofunctional disorder. It's a problem of sensorimotor connectivity. The brain's wiring is physically intact, but the integration between sensory input and motor output is scrambled.
So by lightly touching the chin,
The patient sends a novel, normal afferent sensory signal into the parietal lobe and basal ganglia. That new tactile information momentarily interrupts the faulty processing loop. It acts like a neurological reboot button, allowing the motor circuit to briefly relax the muscle.
that is just incredible. So the hardware is fine, the software is glitching.
Exactly.
So for the MCCQE, how are we supposed to classify the different types of dystonias?
Classification is primarily based on etiology. Primary dystonias are usually genetic. You'll see mutations like DYT1, which codes for a protein called torcini.
And in those cases, the dystonia is the only issue.
Right. Dystonia is the only neurological sign present. There's no cognitive decline or weakness. Secondary dystonias, on the other hand, happen after an environmental insult physically damages the basal ganglia, think stroke, severe head trauma, or copper deposition from Wilson's disease.
Got it. But the exam loves to test the intermediary category, right? The dystonia plus syndromes.
Yes, and the highest yield of these being dopa-responsive dystonia, or DRD.
Oh, this is a major trap.
You cannot fall for this clinical vignette. The question will describe a young child, typically a girl, who presents with lower limb dystonia. She has a twisting, abnormal gait that makes it incredibly difficult to walk.
And crucially, her symptoms display diurnal variation, right? They are relatively mild in the morning and get progressively worse as the day goes on.
Exactly. And the trap is that her presentation looks almost exactly like spastic diplegia cerebral palsy.
But if you misdiagnose her with CP, you are missing a completely curable condition.
100%. DRD is caused by a genetic deficiency in the synthesis of dopamine. If you give this child a tiny low dose of levodopa, she will experience a miraculous, near-total recovery. Her gait will normalize.
Recognizing DRD changes a child's entire life trajectory. Do not assume cerebral palsy in a child with twisting postures without considering a levodopa trial.
Absolutely.
So for general management of other dystonias, how do we approach it?
It depends on the distribution. For focal dystonias, like the cervical dystonia we discussed, or blepharospasm, where the eyelids forcefully clamp shut, targeted botulinum toxin injections are the first-line treatment.
And for generalized?
For generalized dystonias, especially those with childhood onset, we typically use high doses of oral anticholinergics, like trihexyphenidyl.
Okay, I want to circle back to surgical management for a second. In Parkinson's, we use deep brain stimulation, or DBS, targeting the subthalamic nucleus. When you turn a Parkinson's DBS device on, it works almost like flipping a light switch, you know? The patient's tremor stops immediately on the operating table. Is it that same immediate magic for severe dystonia?
It is not, and the contrast is profound. In dystonia, the DBS target is usually the globus pallidus interna, or GPI, but when the surgeon turns the stimulator on, you might not see any clinical improvement that day or even that week.
Really?
Yeah, the effect is severely delayed. It often takes weeks or even months of continuous electrical stimulation to see the full benefit.
Wait, if the electricity is flowing and blocking the abnormal signals, why does it take months to see the muscle relax?
Because dystonia is that software problem of abnormal sensor-motor connectivity. The DBS isn't just jamming a bad signal like it does in a Parkinsonian tremor. The continuous electrical field is slowly forcing the brain to undergo neuroplasticity.
Oh, wow.
The entire sensoromotor network requires time to structurally and functionally rewire itself to adapt to this new signaling pattern. The clinical delay is actual proof that dystonia is a network connectivity problem, requiring the brain to physically rebuild its pathways.
All right, let's take a breath and synthesize everything we've covered. We tackled 3 massive topics. First, Parkinson's, defined by bradykinesia, rigidity, a rest tremor that reemerges with maintained posture, and that crucial non-motor prodrome that climbs up from the gut.
Right.
Second, spasticity, a velocity-dependent upper motor neuron sign caused by lost descending inhibition, managed with a strict stepwise approach starting with noxious stimuli removal, followed by high-yield pharmacology like baclofen and dantrolene.
Exactly.
And third, dystonia. Those maintain twisting postures driven by faulty sensor-motor integration, temporarily relieved by sensory tricks, and uniquely responsive to neuroplasticity via DBS.
You've got it.
So what does this all mean? Why did we spend all this time going deep into the mechanisms instead of just reading lists of symptoms? Because on the MCCQE and on the wards, recognizing the subtle differences between these motor exams fundamentally alters your treatment pathway.
It really does.
If you confuse the velocity-dependent tone of a spinal cord injury with the constant rigidity of a Parkinson-plus syndrome, or misdiagnose of dopa-responsive dystonia as cerebral palsy, you aren't just getting a multiple-choice question wrong. You are sending a patient down a completely ineffective and potentially dangerous pharmacological road.
The clinical exam provides your coordinates, but the pathophysiology is the map you need to navigate. Before we wrap up, this raises an important question, something for you to ponder as you hit the question banks tonight.
Lay it on them.
Think back to the break staging of Parkinson's. If the alpha-synuclein pathology truly begins down in the gut's myenteric plexus and travels up the vagus nerve for years before motor tremor ever appears, could the future of movement disorder prevention lie not in brain therapies, but in treating the gastrointestinal tract?
A completely different way to look at neurology. Good luck on your exam prep. Trust your studying, and we'll see you on the next deep dive.